Wow, what an afternoon, what a morning, what exciting events we've had all day long. This has been by far the best yet. We've worn out this venue, it looks like, in terms of the number of people that are here today, and the program has been great. I wanted to take a moment before we introduce our speaker and ask Larry Morgan, the chairman of the BayCare board, to come up and make a few comments. Larry has been a passionate leader for quality, really asked the questions about how we're doing from a quality point of view, and has led us to the focus of being top decile as an organization. So please welcome Mr. Larry Morgan.
Well, thank you, everybody. This is always a great event for me to attend. I've been doing it, I think, since you folks have been doing it. And I second everything Steve says. It just continues to grow and improve. And I'm a businessman, and you know, when I try to talk about healthcare to some of my colleagues, I tell them how would they like to have the challenge of improving quality and reducing costs all at the same time. And you know, they frown and they look at me like, you got to be kidding. Those two things don't go hand in hand. Yet that's the task that you folks and all of us that are involved in healthcare have been presented. And I want to congratulate you for doing a fabulous job. You know, things at BayCare are pretty dynamic right now. I know you folks know all the things that are going on out there. And I think in any walk of life, if we all work hard at communicating with one another, things certainly do fall together in a much more successful way. And today is just a perfect example of that. And you folks getting here together to, you know, share everything that you know and share your ideas and talk about it and make things better for everybody in our community. So with that being said, I just want to thank each and every one of you. You're great contributors. We have a great organization. We're going to work hard at getting better. And we thank you, everybody on the board and our community, is much appreciative of the work you do. Thanks.
Follow Larry. I have to bring the mic down. So it's my privilege to introduce our guest speaker today, Dr. David Nash. I think I first met David, I don't know, 15 or 20 years ago maybe, from the American College of Physician Executives, when he was back then really the founder of the quality initiative and putting together the training program for the American College, which happens to be based right here in Tampa. But Dr. Nash is, if you look up on the board here, you'll see he's the dean of something that might sound fairly unusual to you, and that is the School of Population Health, which is a lot about what we're talking about today and the direction we're moving and how we want to get there. I think he'll help us understand why it's important that we do. He is a board-certified internist, so he's a real doc, even though we've all, several of us have gone to the dark side. He is internationally recognized, so we're privileged to have him here with us today. He speaks all around the globe. He's highly sought after. He tries to manage his schedule, but that's a challenge, as you might imagine, when you're a talent and you've got the executive leadership and the physician leadership and a message to be listened to in this time and era. You may or may not like the fact that he's sat on just about every advisory council or board there is to sit on, the Joint Commission, the NCQA, the National Quality Forum, name a commission, and he's probably sat on it at some point in his career. So is very knowledgeable in the space. Did put the capstone program together for Sean and others that are having to sit through those things with the ACPE. He's also a very renowned author and editor. Hundreds of articles, several dozen or 20 or 30 books that he's written. The most recent one, Demand Better. You can buy at any Amazon whatever and get Demand Better. And if you read the book, he brings to bear dozens, if not hundreds, of real-life examples of where we failed our patients and how we have to do better as an industry. And that's where the dimension of population health comes to bear. So it's my great privilege to introduce Dr. Nash, and I know you'll enjoy his presentation. Thank you.
Hey, Bruce. Thanks a lot. Wow. This is a quality love-in. And looking around the room, there are some people who are wondering, what's that? So for anybody under 35, a love-in, well, we can't really get into that in public, can we? But this is awesome, so congratulations to all of you. How about a round of applause for Mike Boccaccino and his whole team who put this together? And Bruce, thanks very much for that wonderful introduction. You know, another important acknowledgement is your very own Dr. Bruce is going to fly back to Philadelphia with me tonight because tomorrow morning he's getting the AAFP Robert Graham Physician Executive of the Year Award. So he deserves a round of applause too. So Bruce, one good turn deserves another, so that's outstanding. And we're hoping that USAir practices high quality tonight. That's a little bit of an oxymoron, USAir and quality. What do you think? We'll get into that in some detail. Well, it really is wonderful to be here, and you guys are to be congratulated. I have the awesome privilege of traveling around our great country in venues not too dissimilar to this, but this is the biggest one I have ever been at, even bigger than Baptist Hospital in Miami, so extra round of applause for that. Okay. Also, when I got here just around lunchtime, I asked Mike, I said, do people really stay till 2:15? And he said, yes, because we award the prizes when you're done. Okay, I get it. So my job as the closing speaker is to get us to the conclusion, which that won't be hard. But really, it's sort of bases loaded, and the score is tied. And my job, unlike the Philadelphia Phillies, is to have some real hitting and bring home that winning run. So let's go back to what Steve Mason talked about this morning, because I really agree with Steve. Always good to agree with the boss in public, too. But I really do agree. The presidential election is going to be entertaining for political reasons, but for you and me, our job is pretty clear. There's no new money. Why don't we practice saying that together? You ready? 1, 2, 3. No new money. And that means, look around, we've got to figure this out. That's the punchline of our time together. So to address the question, is population health the secret sauce? I have some fun slides. I'm really going to make 4 main points. So let's go over those first. So part 1, we have a pretty heterogeneous audience from across BayCare. We need a little bit of vocabulary, context. What is all this stuff anyway? Who cares? So part 1, how do we get in this jam? Part 2, what exactly is this corny population health anyway, and where did that come from? Part 3, how does it relate to health reform, which is inexorable, horses out of the barn, happening no matter what happens in November? And then part 4, I'm going to look into my cloudy crystal ball and give you Nash's view of the future, so buckle your seatbelt. All right, so part 1, overview. Part 2, population health. Part 3, health reform like you've never seen it on Meet the Press. And part 4, where are we going in the future? So let's make sure the technology works, and we're going to try to advance the slides, and that's the first problem. Okay, good. All right, my heart rate started to go up. So first, a little bit of geography, because I'm sure most of you don't know Thomas Jefferson University. It ain't in Virginia. It's in Center City, Philadelphia, birthplace of our nation, birthplace of American medicine. 3 blocks south of my office is America's first hospital, Pennsylvania Hospital, founded by Benjamin Franklin. Good try. Listen, if you're in Philadelphia, you want to know founded by, just say Benjamin Franklin. You're going to be 80+% right. So Jefferson is a health sciences university. So this is a picture of our beautiful gymnasium and the floor of our basketball court of our undefeated basketball team, because we don't got one. And all we do is graduate leaders in healthcare in 6 schools, and we'll come back to this in a little while. Jefferson Medical College, the largest private medical school in the United States, with the largest number of practicing living alumni of any medical school in the world. the nursing school, pharmacy school, graduate science school, allied health school, and the meanest, smallest, youngest school, the School of Population Health, and I'll come back to that. But your geography of Pennsylvania and Philadelphia is awfully important. Second thing I thought would be important is this. Now, it's a little hard to read in the back of the room, and I do apologize that it's a little bit after lunch. But if you could look carefully, you'll see this is from the Jefferson Archival Collection. This is a tobacco smoke enema machine. Now, we got a lot of board members up here, so this is particularly relevant. Particularly relevant because the clinicians in the room know this is the etiology of the expression, blowing smoke up your butt. We really did it. Now, part two, as a poor primary care general internist, if we had a CPT code for this puppy, you know we'd be doing it today. So you'll be thinking about blowing smoke up your butt. You saw it here first. This is a clinical pearl take-home message of our time together. Okay, well, here's another message, whatever your politics. Now, this is not an internet doctored cover. This is the real thing from the British news magazine, The Economist, our President Obama. This is going to hurt. It's actually a 3-year-old cover. And get a load of the size of that syringe that the president has. This is really going to hurt. He's right. He's right. Anytime you change the status quo, it's going to hurt, especially when you're mucking with about 19 to 20% of the world's largest economic engine, namely the economy of our great country. So this is going to be a challenge, whatever your politics. I'm not interested. The real issue is we are in charge now of trying to fix this, and that's the challenge that we face. And to Steve's opening comments this morning, I think you're going to resonate with this slide that I love because it really sets the context for our time together. So you could read along with me. All integrated delivery systems like BayHealth, BayCare, are accountable to the public for their degree of success. If this initiative isn't taken by you and me, it's going to be taken by the lay public. Wow. 1918 is where this comes from the inaugural meeting of the American College of Surgeons. Now, this is particularly amazing to me that our surgical colleagues were thinking about this, but that's a separate issue altogether. But 1918, folks, at the Waldorf Astoria Hotel on Park Avenue in New York City. This is World War I. Our surgical forefathers, no girls in this group, were thinking about the issues that we're here talking about all day today. Because if we're not going to take charge of this mess like you're doing at BayCare, it's going to be other people mucking in our work. So I'm all about leadership coming from our industry, exactly like BayCare is doing today. So that sets the context for our time together. Other things you've reviewed already today are this cover story from the Physician Executive Journal from the College of Physician Executives, not too far from here in downtown Tampa. So this is their cover story, moving from volume to value. You know, I grew up, like Bruce and like most of the doctors in this room, more is better. More tests, more patients, more beds, more towers, a bigger garage, more stents. By the way, the record at our place is 13 stents in one patient. What's your record? I won't ask. So we're moving from a world of volume, because that was growth, to a world of, is that the right test to do in the first damn place? And what sort of value are we getting for the money that we're spending? And that's like turning around the battleship inside the Panama Canal. Almost impossible, but we're going to attempt to do it as an industry. Another piece of this puzzle is this. Another magazine, Managed Care magazine, instead of paying for performance, did you order the cholesterol level? Did you check the hemoglobin A1C? Well, anybody could do that process measure. What we're moving towards, as this audience knows and resonates with, is payment for results. What did you do with that data, and can you prove on a population basis that your diabetics are doing better? Not just checking the box. Did you get the test? What did you do with the information? Did they follow up? Did they adhere to their medication? Those are the kinds of outcome measures we're going to be looking for, and by the way, how we're going to get paid in the future. Well, it's not all that easy, of course, and maybe you've seen this famous Business Week magazine now called Bloomberg Business, and to your board chair's point, we can improve quality and lower costs at the same time. That's the wonderful piece of what this whole day is about. But here's some of the challenges that we're going to face. So you could read the subtext with me, medical guesswork from heart surgery to prostate care. They always get that in there one way or another. The medical industry doesn't really know what works. Well, gee whiz, that's kind of an aggravating cover, don't you think? Spin that doctor around on that roulette wheel, that's pretty frustrating. So what's this all about? Well, it illustrates that about half our bills are paid for by employers, the other half by Uncle Sam. And the stark reality is, as a clinician at the bedside, in the office, in the hospital, wherever, the nurses, pharmacists, and doctors know this, 18% of what we do is based on solid, grade A, randomized controlled trial evidence. The other 80+% is the art of medicine. Now, I'd be the last guy to impugn the art of medicine, but we got a couple of problems with that art. First of all, it's incredibly expensive. Second of all, it has a lot of unexplained variation. And finally, the people who pay the bills are not connoisseurs of great art when it comes to medical practice. They're on to us. They know that in our great country, medical care is delivered by zip code. You're probably familiar with zip code 33444, not too far from here, in your great state, where Charlotte Nash, my 82-year-old mother, happily lives. Ground zero of Medicare overutilization. In calendar year 2011, Mom had count them, 3 MRIs for her hiatal hernia. Let me let that sink in for a moment. For non-clinicians who are with us, you would never get 1 MRI to evaluate a hiatal hernia, let alone 3. But Mom said to the doctor, I have burning chest pain and it radiates, and since nobody ever called the other doctors and they're not linked on an electronic medical record and they get paid to do piecework, oh, and Mom's a retired New York City school teacher with wonderful Empire Blue Cross Healthcare and Medicare, she is in the vernacular a whale. 3 different doctors ordered 3 different MRIs. My kid brother, a cardiologist, Thanksgiving 2011, when Mom came up to New York for Thanksgiving, I said to my kid brother, half serious, shut the lights, let's see if Mom glows in the dark. Now, who paid for those 3 MRIs, colleagues? Look around, you and me. Outrageous. But if you pay doctors to do piecework, what are you going to get? Piecework. That's just normal human behavior. And with us, all of us A-plus neurotic students, we're going to do piecework every stitch we sew on that button, not just the button. And that's how we're going to charge you. That's otherwise known as a CPT code. How do we stack up against the rest of the world? This story you know. But if you want a wonderful reference, that's why I put this PowerPoint in here. So mirror, mirror on the wall, the Commonwealth Fund, June 2010. When you add it all up, the United States in 2010 spent $8,000 per person, including children, on health care. So you go home tonight and you ask your family, did we get $8,000 of value for every family member in our family? So I have 3 almost adult children, plus my physician wife, that's 5 of us, times 8, $40,000. Did we get $40,000 of value out of our healthcare system in calendar year 2011? Not even close. And how do we do based on what we spend is really a national embarrassment. And we're going to come back to these measures of societal well-being because, sure, medical care is an important part of it, but it ain't the whole story. So just to summarize, we're somewhere in number 23 to 25, depending on how you count, worldwide, based on the outcomes, based on what we spend. So that's an embarrassment. Another embarrassment, not true at BayCare or Jefferson, but everywhere else this is a huge issue. Everywhere else we worry about uneven adherence to the evidence. What's this about? Well, the docs in the room are familiar with this. This is Elizabeth McGlynn's work, 10 years of study, multiple papers in the New England Journal of Medicine. Main message, if you believe the research from the best folks in the business, by the way, Elizabeth is now Senior Vice President for Outcomes at a small outfit in California called Kaiser Permanente. So Elizabeth and her colleagues looked at thousands of charts at hundreds of hospitals, largely on the West Coast, published this in the New England Journal, and compared research-based evidence on what we ought to be doing based on quality indicators, something this audience knows a lot about, and then compared based on chart review what they actually did. And colleagues, you could see the answer up there. On average, we got it right about half the time. What's going on? Well, you and I know complex systems, lack of systems thinking, lack of a just culture, slavish adherence to personal autonomy, fancy way of saying doctors do what they're trained to do. Another thing illustrated by this, you know the old saw, of course. When specialists have a hammer, everything to them looks like a nail. Only the United States has 3 specialists to every primary care doctor, when every other developed Western nation has an exact reverse ratio. 3 primary care doctors to every specialist. That's what we need, and that's in part what leads to this uneven adherence to the evidence. Just to illustrate again, atrial fibrillation, second in from your right. My late father, who had atrial fibrillation in his last 2 years of life, I took my cardiologist kid brother and my cardiologist uncle. I put them in a room in Boynton Beach, Florida, 33444, and I said, what are we going to do about Dad? 5 hours later, they were still talking, rather loudly, I might argue, too, because they couldn't figure out, should we anticoagulate Dad? If we do, which drug should we put him on? How much testing will he need? Good Lord. So this evidentiary basis, plus complex systems, plus 20% of the GDP, you get the idea. We're in an incredibly complex business. You know that. You have a whole day devoted to trying to sort aspects of this out. Another of our challenges, just like your board chair alluded to, is the business community is onto us. They're not all as sympathetic as your board leaders. Groups like the National Business Coalition on Health, the National Association of Manufacturers, and others with whom our school works closely, they are deeply engaged in the work that we do, and they know all about unexplained clinical variation. They know that medical error is the 4th leading cause of death in the United States in October 2012. Shame on us, everywhere but BayCare and Jefferson. So this is a challenge from the people who pay the bills perspective, at least half the bills anyway, in the way our crazy patchwork quilt system is organized. They are wise to our secrets. They probably have some spies in this room right now learning our deep process-oriented and outcome challenges that we all share. So, to Mr. Morgan's comment, thank goodness it is possible to improve care and lower costs, first articulated in the peer-reviewed literature by one of our fathers of our movement, the great Don Berwick, way back in 1998. By the way, Don's out of a job now, so if you got some employment for him, I'm sure he'd like to hear from you. But all seriousness, this is the first time I could find this in the peer-reviewed literature, now a long time ago, 1998, when Don said it's possible to improve care and lower costs. How would you go about doing that? Well, in our crazy business, one person's cost is another person's salary. Let me illustrate. So here are 6 boxes. This is from the Domains of Excess Cost out of the Institute of Medicine, very reputable source, June 2011, a little over a year ago. And our colleagues at the IOM were looking at how could we really bend the cost curve. And they illustrated it with these 6 boxes. And the biggest box they call unnecessary service. Now, you know in BayCare, and we know at Jefferson where some unnecessary services are, but we're holding on to those services because all of those unnecessary preoperative chest x-rays keep the Department of Radiology in business. And a lot of those unnecessary laboratory tests do the same for the lab. Now, if we were all paid in the same direction and had aligned incentives, maybe we could reduce that big box. Wait, there's more. If you really broke it down in a list, the best way to reduce cost and improve outcome, you and I know, is how? Prevent medical error. Because that's a great example of waste. So, of course, care is never, ever going to be error-free. What we want to do at BayCare in Jefferson is make care harm-free. And if we could even do that, achieve that goal, and that's a governance level directive, if you reduce medical error, that's the #1 way to reduce cost and improve outcome. #2 way, prevent unnecessary admission. Uh-oh.